Well, I am Anna Fojak-Trester. I'm the director of the Public Health, Masters of Public Health program here at Eastern Washington University. We have fully online and in-person programs here on the Spokane campus. And I want to mention that our application cycle is just opened. So those of you out there looking to get an MPH, we're definitely excited to start developing our new cohort. The vision of this Grand Round series is to work at an interprofessional level to bring the public health interests to everyone. Public health is really the glue that keeps us together. It gives us an understanding of why our actions and behaviors matter on a bigger scale and how that bigger scale impacts the behaviors and decisions we make every day. And so the vision for this series is to help bring specific topics that are of particular crucial interest and help us understand where we fit in. And we can find our place, and if we can't find our place within that map, we can hopefully learn greater compassion for those who might be disproportionately affected by some of these issues. In public health, we're very much about equity and thinking about health in terms of community. So we hope to always bring that to our speaker series here. I will, at the end of this particular session, I'll highlight what we have coming up at the end of the month as our regular Grand Round series. We will have another one on the 25th as well, and we'll talk more about that after. So let's move along here. Our speaker today is Renee Fullerton, who joins us from Olympia. Are you in your office right now?
I am. You know, the glamorous state office is behind me.
Renee joins us from the State Department of Health, where her passion and her time is spent understanding our whole health workforce, not just primary care, but oral health care and mental health care, and looking at and facilitating possible solutions about what we can do as a state to get a fairer distribution of our health workforce across all these communities that really need it. So without further ado, Renee, you can take over.
Sure. And so I must freely confess that this is a really big topic to try to cover in this time frame, and I always have so much in my brain when asked to talk about healthcare workforce. It is hard to narrow, so I'm going to do my best to keep within the time constraints that we have today. And thank you for your introduction. I appreciate it, and I appreciate the opportunity to talk about Eastern Washington and the workforce challenges that are going on over there. So healthcare workforce, like who is that? Who's wrapped up in that particular label? So healthcare workforce is everyone that's working in the healthcare sector, both clinical, doctors, nurses, pharmacists, physical therapists, kind of everyone you think of who has a credential, but also a lot of folks you might not think of, like information technology experts, administration folks, the billing staff who make sure everything gets coded and everybody can get paid, home health aides, environmental services, the volunteer EMS folks who are out there, you know, doing the hard work alongside the roads and in people's houses. It all makes up our healthcare workforce. And the other funny thing is, DOH, Department of Health, isn't what you think of as a workforce development agency. That's not really our mission. We're a public health agency. There are other facilities and state and agencies within the state that handle those particular responsibilities. But we are very concerned about patient safety and overall access to the needed healthcare services for our population. If we don't have a safe and effective healthcare workforce in our high need areas, then we have a healthcare access issue, and that's a big problem. So for those of you who are in public health, it sounds like it's a mixed group, you're probably familiar with those adages about social determinants of health and how economic determinants and social determinants make up the majority of a population's health status. But there is that 20% of population health that's determined by access to healthcare services. And that's not a trivial amount of a population's health. And it's particularly relevant if you've had a car accident along a rural highway or you're having a stroke outside a major metropolitan area. Are you going to be able to get to those services that are going to extend your life? Or might that be the end if you're not able to get the services you need? So looking at this idea of rural versus urban, it's good to have a common understanding when we're talking today about what a rural community is, because it varies a lot depending on who you ask. I do a lot of recruitment, and when I talk to folks who've maybe grown up in Seattle and haven't been around a whole bunch, they might think of Issaquah as rural because that's their particular frame in their brain. But if you talk to someone from Eastern Washington, you know, you get an entirely different picture. Using our state definition in Eastern Washington, the two urban counties are Benton County and Spokane County, and then everything else is considered rural for our state purposes. And then some definitions of rural get much more granular than that, because of course we have very large counties here in Washington state, and some of our urban counties have rural areas, and some of our rural counties have urban populations. And this comes into play when you think about Chelan and Yakima counties. The majority of the population are actually living in urbanized areas, although some communities like Manson and White Swan are quite far from tertiary healthcare services. So taking a look at the rural environment in general, what kinds of healthcare access disparities do we see when we look at it? For our research purposes here, we use the RUCA codes, which are rural urban commuting areas. They were developed by the University of Washington Center for Health Workforce Studies back, gosh, I think going on 20 years ago now. And they look at the interconnectedness of places. Are people flowing from a rural community to a more urbanized center for work, or are the people staying put in that rural area is much more isolated? People aren't traveling out so much. And so when our rural epidemiologist compares rural Washington with urban Washington, we can see some real differences emerge. So on average, when compared to urban residents, are less likely to have health plan options to purchase. This is referring to the exchange that came about following the Affordable Care Act. For some years, we've had to have some real, incentivizing going on to make sure that there was at least one health plan offered in each county in Washington state. And those counties that didn't have health plans offered until the insurance commissioner stepped in, they were rural counties. People in rural areas are less likely to have health insurance overall and less likely to have a personal health care provider. There are overall higher rates of unmet medical needs because of cost, and overall they tend to have lower incomes and higher rates of poverty in these communities. So one particular demographic factor I always like to pull out when talking about rural versus urban here in Washington state is the aging of the rural Washington population. So in 2017, we had these 8 highlighted counties that you see here had more than 25% of their population over age 65. By 2025, they're going to be up over 30% of the population in those areas. And then you see by 2040, we can see that accelerating trend continue. Rural Washington is already significantly older than urban Washington. Over those next 20 years, it's going to get even more pronounced. This is going to naturally lead to more pressure on the rural healthcare system because older adults naturally are more challenged by healthcare problems. About 80% of older adults have at least one chronic disease, and 77% have at least 2. It's interesting to note that among percentages of children and young adults, our rural and urban areas don't look all that different. Some rural communities have populations significantly younger than the overall population. There's a significant need for services like maternity care. Adams County is one that in particular that comes to mind with Othello. The hospital there delivers a lot of babies for being a critical access hospital. Where rural and urban significantly differ in the percentage of working age adults and the percentage of elderly individuals. So when you kind of look at what this particular chart is showing is that your workforce, there's people who are of the age when they're going to be out there providing care potentially in the healthcare system. And you just have many fewer overall in the rural communities than there are in the urban places. This has profound implications for just workforce overall. There are fewer workers. This is compounded by lower education levels in rural communities and less access to higher education required to become a credentialed healthcare professional. It's not easy to become a doctor. It takes a long time. It's not even easy. It's definitely not easy to become a nurse. It's very challenging to access nursing education if you don't have an option there in your community. And many of our rural communities don't. So thinking about the sort of structure of rural and these sort of factors that are going on, let's kind of take a big step back and look at healthcare workforce in general here in the United States. And it's an industry. It's big business. It's one of the major economic engines in the United States, and it's also a service-based industry for the most part, which means it needs a large workforce to carry out those services. There are several reasons that underpin this rise of healthcare, some related to demographics and some are related to policy decisions. In 2017, I guess that's not last year anymore, healthcare sector actually outgrew retail and manufacturing in the number of jobs across the United States. It's massive. Part of the reason for that is that overall aging of the U.S. population, there's greater demand for healthcare services. Also, healthcare is resistant to the typical business cycle. For those of you who were around in the workforce during the recession back starting in 2008, healthcare was one of those sectors that did fine and actually added jobs during that Great Recession period. And that's because it's subsidized basically by taxpayer dollars. The majority of Washington folks, so you think about it, are either on Medicare or Medicaid, and those are financed with taxpayer dollars. And so that's different than if they were going through a regular business cycle. Right now, the last time I looked in 2018, about 24% of the state is insured through one of the Medicaid programs. And then you think about those rural communities with 25 to 30% seniors, those folks, majority to almost all, are going to be insured through the Medicare program. It's also an industry that's resistant to globalization and automation. It's a hard one to outsource on the whole, as opposed to some of the other technological jobs that are out there that are either being sent to other countries or manufacturing being sent to other countries. As a service-based industry, it's provided in the community for the most part. Telemedicine, people are really excited about it. They think it may be able to augment, but I don't think it's going to replace, at least not anytime soon. We see telemedicine applications used to increase access to specialty services, things like telestroke, where you get to your rural hospital and you're able to connect via telemedicine with a physician in a tertiary care center who's able to check your neurology symptoms and advise the physician in the rural community about how to treat you. But that doesn't take the place of having the rural hospital or the rural services in the first place. So in thinking about the healthcare sector and why there might be workforce challenges, another thing to consider is what's going on with the economy in general. The workforce for the healthcare sector exists within the larger market for labor workforce, and it's in an economy that's doing really well right now, at least here in Washington state. I pulled the numbers for November. They are the most recent available, and we're sitting at statewide unemployment of 4.3% across the state. During the last 12 months, 11% of all jobs created were within health services and social assistance positions. Now, I like to pull this map that breaks it out county by county because it shows you that while statewide we have this pretty low unemployment rate, within our rural communities, we show areas with much higher rates of unemployment. And there can be a couple different reasons for that. It's been an ongoing challenge, unemployment within our more rural counties, and several different reasons for that. Can be less access to on-site higher education that you need to become a healthcare credentialed professional. And folks, it's also some changing going on with these sectors. Like if you're familiar with, say, Ferry County, you know that within the past 2 years, the gold mine that was there, that was a substantial employer, closed. And so you lost, I believe, around 200 jobs within that particular facility, and that's not necessarily a group of workers who are going to easily transition into working within a service healthcare focused side of things. It's a big change to go from an extractive industry to working in healthcare. So in thinking about workforce overall, I thought that I would take sort of a domains approach. So we're going to walk through this starting with primary care, then going to a little bit on behavioral health, and then going to oral health. So this section here, it's going to get a little bit healthcare systems focused. Anna thought that might be some good broccoli type medicine for you all to get a little bit of grounding in how the system works out there in the field right now. But in most areas, these facilities are also going to be well connected with their local health jurisdictions, their local public health departments as well. Because in rural areas, you know, it's not a whole bunch of different people. Everybody knows each other when you live in a rural community if you're working within the health sector, whether it's public health or healthcare. So they're main players that most people think about when they think about healthcare in rural communities. Big one, and one that we're actually trying to, you know, have less of, not numbers of hospitals, but people needing hospitalizations, are the hospitals. Critical access hospitals are 25-bed facilities or smaller. Many are much smaller than that here in Washington state. We have 39 here. Then we also have our larger rural hospitals. Examples of this would be Samaritan in Moses Lake, Central Washington up in Wenatchee, variety of the larger tertiary facilities, but not as big as, say, Sacred Heart there in Spokane. And one interesting thing for our hospitals here in Washington State, and I think it's to our advantage, is that they are frequently public. They are public hospital districts that have a taxing base. They receive support from their taxpayers. They have a local board that oversees running of the hospitals, and I think that keeps them much more accountable to their local communities. All right, another important piece of the rural healthcare infrastructure are rural health clinics. A rural health clinic isn't just a clinic that's in a rural area. It's an actual designation that comes from CMS, the Medicare system, and it has to do with how these facilities are paid. They can be freestanding or they can be owned by a hospital. And over the last 8 years that I've been doing this kind of work, there's been a big shift from sort of freestanding independent physician clinics, if you think of kind of that old school Marcus Welby view of care, towards ownership of these clinics by hospitals, either the critical access hospitals or the larger rural facilities. And that's mostly driven by a payment incentive. They get paid at a higher rate if they're owned by a hospital. Sorry, acronym land here. Community health centers or federally qualified health centers, they mean the same thing. These are nonprofit healthcare facilities. They provide medical, dental, and behavioral health services. They serve a majority Medicaid client base, and they also receive some federal grant funds to serve underserved populations. We have tribal health clinics here in the state. Most of our Washington tribes have taken the funds from the federal government back and provide services themselves. They manage their own clinics. We also have a few Indian Health Service clinics still here in Washington State, where care is provided by Indian Health Service personnel, uniform public health service folks out there. And then sort of the last one is the behavioral health agencies. These are primarily the Medicaid serving facilities that serve behavioral health needs within both rural and urban. And these entities are undergoing a lot of change. You may have heard there's a lot of work going on right now within Washington State to better integrate our primary care and behavioral health systems. And so there's a lot of change, interfingering, everything going on along with the behavioral health agencies right now. And their regulation has also changed a lot too recently. So it's not just these facilities, it's all of these plus many other important pieces, but I didn't want to fully drag you down into the minutia of describing the healthcare system. But don't want to forget EMS, private practice, home health, hospice, lots of different types of players out there, and they're typically very interfigured within rural communities. So that's a lot to kind of walk through. So I thought I would take you on a little bit of a visual tour since we have the benefit of this technology. So this is a map that just shows the critical access hospitals here in Washington State. They vary a lot in their services. As I said, they're 25 beds or fewer. They have an average 96-hour patient stay. Some are quite large. They're up right at that 25-bed limit. They have large surgical programs, intensive care units. They deliver a lot of babies. They're important access points. Others are also important access points for senior care. They may have very low inpatient admissions, maybe one averaged a month, which is very small for a hospital, but they use a lot of swing beds and provide a lot of skilled nursing care. And that can be a really important thing in some of those communities that skew much more elderly, that may not have any other sort of skilled nursing facility in the area. The other practical thing with these facilities, they're also major employers in their area. And they're big contributors to their local economy. If these hospitals went away, it wouldn't just be access to care that you would lose. You would take a big hit economically in one of these communities if the facility closed. They pay good wages, they pay good benefits. They're an important part of all of it, the system. And over the past decade, they've also taken a large role as physician employers through that consolidation that I talked about, where the hospitals have taken over management of the clinic. And they've done that not because primary care is a money winner for them. They do it because it helps ensure access to primary care in their community at all. Because if the doctors go, you can't really run the hospital. So this, advancing. All right, so we just had the purple ones add on, and those represent the community health centers here within Washington State. The community migrant health centers come from the 1960s, and Lyndon Johnson's War on Poverty. They receive a federal grant to provide care to individuals without insurance, but they're mostly funded by insurance payments, majority Medicaid. As you can see here, we have a lot of them. We're a heavily SQHCI'd state, and they're both rural and urban community health centers. But you can see there's also a lot of gray areas, a lot of rural areas that are not served by a community health center. In particular, on the east side, if you look, Klickitat County, Lincoln County, Columbia and Garfield, Whitman, and Asotin have pretty minimal to no community health center services there currently. But then other parts of eastern Washington are heavily served by community health centers. The Yakima Valley is one I think of as having lots of community health centers. Spokane is greatly served by CHAZ. You get up here, you get Northeast Washington Health Programs. There are a lot of really strong community health centers that have a great tradition of service to their underserved communities within eastern Washington. We're going to click over next. So these orange dots that just popped up are the rural health clinics across the state of Washington. We have about 120 of these here in Washington. You can see by the map that they fill in some of those dots where there weren't pink spots before. So now we're showing service in Lincoln County. We see service pop up in Klickitat County, Goldendale, White Salmon. You see them show up in Columbia County, Garfield. So they are also really a vital part of the system. And then the map is getting really busy at this point, so thank you for bearing with me. It's nice to show everything in layers, but it's a little challenging too. The red circles that just appeared, let's see if I can show you with the mouse. This one, this one, this one, this one. These are tribal sites, both IHS and tribal services. In eastern Washington, you can see some down here on the Yakima Reservation, Spokane Reservation, Colville Reservation. And then we have two urban Indian health programs here in the state, one over in Seattle and then Native Project here in Spokane that serve Native Americans from a wide cross-section of tribal groups. And then the last group I talked about, I don't have a good map for the behavioral health agencies, but they're also a vital part of this whole network that's providing care across the state. So altogether, these rural facilities need the complete continuum of healthcare workforce. They need volunteering MTs, they need medical assistants, nurses, dentists, surgeons, healthcare administrators. There's too much that they need to really dive into in depth in this particular presentation. So I'm going to now walk through kind of three different areas and how the workforce is influenced by the different policy decisions that are made and oftentimes by billing, what people are able to bill. So let's start off with access to primary care. I'm going to walk through a specific provider type that we have been doing a lot of work on here in Washington State through some legislative appropriations and work through the UW Family Medicine Residency Network. Family medicine physicians are a key clinician type for many of our rural communities because they're able to provide care across the entire lifespan, including obstetrics, a variety of procedures if they're trained on them. They can do you from your birth, take care of the baby, do the adolescents, take care of the seniors. They're wonderful in that particular regard. And rural areas are facing greater challenges recruiting family medicine physicians to serve their community needs. A couple different reasons. They're aging. The rural physician workforce, it tends to be older than the urban physician workforce. And we're reaching this point, the sort of tipping point with the boomer generation aging out of the physician workforce, and it's key to replace those physicians in those clinics, or you can lose access if a clinic closes, and it may not be restarted again down the line. Research overall finds that family medicine residents have a tendency to practice near where they are trained, and this is profound because most of our training is done in urban centers. And so when you're training the majority of your potential workforce in an urban setting and you're training them, perhaps in more hospital-based settings and we want them to practice outpatient, you're not necessarily going to get the outcomes that you would like from that. So in 2016, the legislature passed significant legislation with the goal of increasing the number of family medicine residents training in shortage areas by providing financial support to hospitals and clinics to take on these residency programs. And then we do a report that kind of looks at what's happening because of those funds being dispersed across the state. And the goal of those funds was to increase the number of our training programs because overall we were under-residented. Residency education is not evenly distributed across the United States. There's a big concentration on the East Coast, and Washington State on the whole does not have the number of residency programs that you would expect to see for a state and population size that we had. So where are we training the residents? And how many do we have? So this map shows the number of resident family medicine training by county during fiscal year 2019, at July 1, as of 2018. So this is 408 family medicine residents training in the state. And you can probably do the numbers in your head, but basically 75% of those residents are training in Western Washington. So we're looking here at Eastern, you have about a quarter of all the residents being trained here. Of the 101 that are training east of the Cascade Crest, really just 12 are training in rural type settings. Those would be those here in Kittitas County and those here in Stevens County. Yakima gets a pass for being yellow under the OFM designation, but Yakima itself is 100,000 people, basically. So it gets sort of, for me, it's not so rural just because they're very much so on the larger side of things. And the class, our graduating class coming out in 2019 is going to be 127 family medicine physicians. We've grown our programs since 2016. We started new programs in Kitsap County, here in Bremerton. We started a new rural program here in Port Angeles, another program that's rural-ish in Marysville. And there's discussion to grow additional programs in Arlington and Elma, and then here on the east side in Spokane and Pullman and Walla Walla. We're growing. The good news is we're growing. Things are getting better, but it takes a lot of time. It takes 3 years to train a family medicine physician from start to finish, and it takes a couple of years, of accreditation and getting everything set up before you even can set a resident along those paths. So it's definitely a long timeline to get these particular individuals out the door. But what really also matters is eventually down the road, are these physicians that we're training in these programs we've funded staying? Are they choosing to work in rural communities, or are they electing to go to urban centers? And a lot of that has to do with who's getting into medical school in the first place. Are they students coming from rural areas? Do they want to go back? And are they able to be supported in good training locations like where they want to work later on? Are they being supported in their goal of wanting to do primary care and go back to a rural environment? And more important, very importantly, if they have met and married somebody along this whole educational path, is that partner willing to live in a rural community? I lose a lot of folks not because the doctor doesn't want to work in a rural community, but because the spouse doesn't want to live or believes they can't find a job in a rural community. And that's a big challenge for us. So we have some initial outcomes, and these are practice decisions sort of for 1 year following graduation about where the classes of 2016 and 2017 for family medicine residents went. And so we rounded up the west side urban counties and east side urban counties and then grouped the rural together as well. And we just sort of did a real rough population level estimate. Did the percentage of the state's population in that area roughly line up with the percentage of residents that chose to go work in those areas? And you can see for Western rural and Eastern rural, it actually stayed pretty level, which we were happy to see. It was interesting that we had kind of this drop off from the Eastern urban counties that we had more, because about 12% of the residents trained there, but only 6% stayed. And so it's interesting if are they going to the more rural locations in Eastern Washington, or are they going, elsewhere entirely? That's a question I don't have the answer to. But it was interesting to note that the rural seemed to be doing okay or getting better, and then urban was having a little more challenge on the east side. But that's not to say that significant challenges don't remain, even though we are hopefully getting on this little bit better trajectory so far as physicians choosing to go work in rural areas. So out of the graduates from 2017 that remained in Washington to practice, we had 15 of them choose a rural county. So here in my office, just to sort of get a sense of scale, we have a direct recruitment program that works to find physicians to work in our rural health clinics, community health centers, all those rural facilities. And during that same period in 2017, our program, we had 31 family medicine openings across our rural counties. So even though we had 15 choose to go rural, we still had a lot more surplus vacancies out there that we were not able to fill with folks coming out of our Washington state programs. So, you know, there's pluses and minuses in all of this. It's good that we're increasing the number of residents training in rural locations. It's good that we're having more grads choosing rural compared to 2015. We definitely still have some challenges with rural openings remaining unfilled. Rural retention also varies greatly. That's one other piece of this is, yes, they can choose rural practice, but are they retained there over the long term? How long are the physicians going to intend to stay? Because that has a lot of implications for continuity of care in the community. Are people able to have a long-term relationship with their physician, or are physicians cycling through in 2 to 3 year periods, which can be pretty disruptive? And then we still have this sort of looming rural physician workforce that is retiring. I talked to many doctors out there who are trying to find physicians to take over their practices and not necessarily having much luck finding anyone. So for these reasons, our rural communities are continuing to rely on sort of other professions and other sources of physicians beyond the physicians who are coming out of our training programs here in Washington. We have international physicians that come to work in our state. It's interesting, nationally, about a quarter of the national physician workforce are physicians who were not born in the United States. We are large importers of physicians from other parts of the world. We are making great use of advanced practice clinicians here in Washington state, such as nurse practitioners who are able to practice independently, and physician assistants who are able to do a great deal on their own as well. And then we're also doing interesting things with scope of practice around professions like pharmacy that are adding a lot of primary care focused activities to their work. And so in looking at this, the one other thing I find really interesting in the overall physician workforce is what is retention of these physicians going to look like over the long term? Even if we can get them into these jobs, are they going to have a partner that's able to find employment that makes them happy, or be happy in their non-employment choices within that area? Is there enough family support or community support after a doctor has had a child? Are they happy with the school system? That can do a lot for retention as well. Our physician workforce is shifting to be majority female, and family medicine as a specialty is a particularly female specialty for physicians. According to the Family Medicine Residency Network at UW, the recent residency classes have been upwards of 65% female. And in the literature, the female physicians as a group are less likely to choose to practice in rural communities as an initial practice choice. And if they do choose it, they're less likely to be retained. So, you know, we're shifting to a more majority female workforce. We're going to have to figure out how to do a better job recruiting and retaining female physicians to get the workforce we need for our rural communities. So moving from here to access to behavioral health, there has been a lot of focus on this here in Washington state recently because we have some major challenges going on. Access to rural behavioral health services is universal. When I go out and talk to sites, I hear a lot of difficulty recruiting across a wide range of professionals, both the sort of master's level behavioral health folks like licensed mental health counselors, social workers, marriage and family therapists, clinical psychologists, doctoral level, and then also things like chemical dependency professionals to do substance abuse counseling. There are a couple of different reasons that access is really challenging, and some of them aren't necessarily provider. It's not that we're not creating enough providers. There are a lot of billing challenges that are leading to our current workforce shortages. One that people don't realize is we have a lot of licensed mental health counselor programs here in the state. We graduate quite a few licensed mental health counselors each year. And then we have 4 clinical social work programs here in the state. So by far we have more counselors, but they cannot bill Medicare for their services. And so in our rural communities that have not majority, but large senior populations, that creates a real behavioral health access problem for the seniors because they're not, the most common provider type isn't able to bill for services. And so our community mental health centers, which are sort of the primary access point in a lot of rural communities, they may have few or no licensed independent clinical social workers on staff that are able to bill Medicare. And so often they'll be shut to Medicare clients or seeing them on sliding fee scale, especially when Medicaid patient volume is high, because they're required to see Medicaid folks first. They have metrics they have to hit for the state. And so if they're getting maxed out on the number of Medicaid folks that they see, they restrict the access to Medicare patients. Let's see, my train of thought. And then our rural health clinics and our small hospitals that I discussed earlier on the primary care side, they are, as part of this behavioral health integration, are looking to add more behavioral health services. But because they serve a majority Medicare population, they are having to basically solely focus their recruitment on the social worker population as opposed to looking at the larger pool of counseling. Because this is Medicare, not Medicaid, this is something we can't fix here within Washington State itself. Medicare is federal, of course, and so this is something that has to be changed at a much higher level than what we can do here in Washington State. And then another side of the whole behavioral health services, one of the policy levers that frequently comes up when sites are having trouble with workforce recruitment and retention across any domain, be it primary care, oral health, or behavioral health services, is loan repayment programs. Most highly needed healthcare professionals, it takes years of school to get through and do that, and people come out with high student debt loads these days. And the challenge is we have a state loan repayment program here within Washington State, but included within it are those three domains of medical care, oral health care, and behavioral health care. And we have to try to balance who we're awarding across those domains, because there's only so many funds and there are so many more people that need awards and are willing to work in underserved communities in order to get a loan repayment award. The Washington Student Achievement Council administers our state loan repayment programs. 2 years ago, we, the Department of Health, encouraged them to add 4 behavioral health professions to our loan repayment programs that were not previously eligible as part of our attempt to help increase access to care in underserved communities. And so you see these are the 4 professions that we had added to the program. And then psychiatrists, psychiatric nurse practitioners, and physician assistants have been eligible for many years, but it was new to add these guys in. So I'll show you sort of what happened with that. We had, this most recent cycle, we had 392 applicants across all those disciplines. We were able to fund 98 of those clinicians, so about a quarter. And then of those 392, we had 80 that were within those new professions. But, you know, funds allowed us only to award 12. And so this sort of shows the limited impact that some policy levers have. Loan repayment, you know, is great for those 12 folks who are able to, you know, go and work and do great things at their sites. But for the other 68 who were not awarded, we hope they're retained. They may or may not be, depending on what's going on at their particular location and what they're financially able to do. Loan repayment overall, I know Anna mentioned there might be some clinicians, future clinicians in the audience. If you are training to be a clinician and you want to work in an underserved community, there are a variety of options out there. And so catch up with me offline afterwards, and I'm happy to talk through your circumstances, or you can ask questions once we get through all this. All right, I'm gonna get there. All right, access to oral health care. So poor oral health is a challenge for many residents in Washington, not just rural, urban as well. And a lot of that is because of payer issues. So overall, if you look at the disparities, rural Washington residents do on average tend to have less access and use of dental care. And access to care for adult Medicaid clients is challenging because Medicaid rates are set fairly low. And so on the fee-for-service side, and so a lot of private practice dentists do not accept Medicaid clients onto their practices, or accept a very small number of them. And then for our senior population, Medicare, Part A and Part B, they do not cover routine dental care. And so if someone's not enrolled in a Medicare Advantage plan, they have to pay for everything out of pocket. And then overall, some frontier areas, we may not have a dentist practicing there at all. For a while, Ferry County didn't have a practicing dentist coming in. And then one other thing I always like to point out, since you're public health folks and you're into prevention, is population level is whether the community has access to fluoride. That was a big change for me, actually, when I moved to the state here, how low fluoride access is in some of our areas. I'm down here in Thurston County, and I have to give my kids fluoride tablets because we don't have fluoridated water here in Olympia. So the interesting thing about this map is that while there are not too many fluoridating systems, that's what the red dots are, those are water systems that have fluoride, there are therapeutic levels of fluoride in Eastern Washington because the rocks have naturally occurring fluoride and then the water goes across. So these blue ones are ones where at least 2/3 of the population has a medically significant dental fluoride level. And we know that fluoride has great effects on reducing the number of dental caries in our population. So this map, a very unpleasantly covered map, shows the percentage, shows sort of the billing aspect and what insurance type you have can have a big impact on your oral health status. So this map shows the percentage of the enrolled Medicaid population within the county who received any dental service within the fiscal year 2017. And so these bright yellow areas are locations where people who had Medicaid, had dental coverage, did not get any services provided. And you assume, kind of in a basic year, you'll have 2, prophylactic cleanings, and then they may or may not find something. It was very low. People had no services. There was no access there. So we're working on this here at the Department of Health. We have an oral health workforce grant from HRSA where we're trying to integrate into rural health clinics the oral health service line, similar to what the community health centers do, because you'll look at some of these ones that have lower access utilizations are the same ones that did not have much service from community health centers. Community health centers are the primary provider of dental services to our Medicaid population. Overall, in looking at the oral health workforce, recruiting challenges for dentists are somewhat similar to that for physicians. They have high debt loads. They may or may not be from a rural background themselves or be interested in rural practice. But it's also complicated by the fact that while physicians have mostly are on their way towards shifting towards an employed model with a large number of public or nonprofit employers, dental world is still very much small business, for-profit small business. And so most of these more for-profit small practices are not providing very much service. Some do great work, but majority do not provide much service to Medicaid, and so they end up not qualifying for a lot of the recruitment programs, like the National Health Service Corps Loan Repayment Program, the scholarship program, all of that. And so that leads to even greater challenges for them recruiting because they're not seeing necessarily underserved population, but they're still having difficulty recruiting clinicians. It's a challenge overall, and I think dental is something that needs a lot more statewide attention as we go forward. It definitely gets, of the three between medical, behavioral, and oral health, I think oral health probably gets sort of the less attention paid to it. And then, I'm almost done. So one thing to sort of go back to is the idea, when asked to talk about health workforce shortages or sort of during the upcoming legislative session, we always get a lot of asks about information. What data do you have about healthcare workforce shortages? How many people do we need? How many people are we short? Where should they be? What is the ideal state for the healthcare system? And one of the underlying issues is that there's not really strong data available for us right now to assess how we're doing on efforts to increase our workforce. You know how many people graduate for any given year within your educational system, but oftentimes you know how many we license here within the Department of Health, but oftentimes that information is analyzed within the silos of the profession when the overlapping scopes of practice means the access situation on the ground is much more complex. You know, a nurse practitioner has a significant overlap with a physician, also with physician assistants. You see pharmacy also edging into all there. And there isn't a single sort of data analysis tool that looks at the layered effect of all those different professions working together out there in rural communities. This map is what gets pulled up a lot. This is the health professional shortage area designations that were most recently done in 2017. And so this is what people find when they go looking for information about healthcare professional shortages. Shortage in the name. But the challenge, and oftentimes they want to use this as a measure of, are we meeting our goals around healthcare access? The challenge of that is that this is a federal methodology that was developed by the federal government to serve their programmatic purposes, and it gets used for a lot of things it wasn't intended for. Doesn't measure our important Washington differences, like our ARNPs that have full scope of practice, where in many states, some states, you know, ARNPs are still fully supervised by physicians, and that makes a big difference. Overall, I'd say our state is working very hard on some specific investments to assist with getting appropriate workforce to address our healthcare access disparities. Our rural communities are great places to live. I truly do believe that. I always fall in love with the rural community when I go visit it. But some areas are still working to get equal access to important amenities that can help, like broadband internet. I think we have a serious last mile problem that is challenging many of our rural communities, and you can't see a true uptake of, say, remote workers or you know, harness the true ability of the internet if you don't have broadband available in the home. We have a good broadband spine that was built out to facilities like libraries and hospitals during the recession, but we still have that problem of running cables to individuals' homes. So all this to say is, if you are a clinician, or if you're a public health professional, if you're interested in working in a rural community, I really encourage you to do so. Even if you're not sure, go out and take a look. If you want to make a real difference, they are the place to be here in Washington State, just because you're able to be so intricately involved in everything that goes on. And they're wonderful places. So thanks for giving me a platform for which to cheerlead for rural Washington, Anna.
Well, thank you very much, Renee. That was enlightening, and I think any of us involved with workforce at all are always welcome to give you a platform for cheerleading for greater workforce in our rural areas here in Eastern Washington. Okay, so this is your moment. You get to be the center of attention for a little bit. Questions for Renee? All right. Well, Renee, did you have a chance to look at the public health workforce at all? We talked briefly about it. I get emails from rural counties looking for wanting interns because they're having a hard time staffing up smaller public health districts. Did you have a chance to investigate that at all?
So I didn't get it's one of those data issues really as well, in that while at least with the licensed clinicians, we have the information that flows through the department, the information about workforce needs for folks that are not licensed, such as public health professionals, is really even harder to get your hands on. I hear a lot on the public health side about public health nursing being particularly challenging out there. And so if someone is a public health professional and also has that nursing credential, that is a fabulous skill set that is highly used in rural communities. And I would encourage them, to go out and give it a shot. Otherwise, I think anytime you're looking at a profession that is operating at the master's level, that's going to be a challenge for a rural area overall, because people who may be from that area are traveling out to Eastern or to, our other public health programs out there in the state of Washington to receive training. Anytime folks leave a community, they may or may not go back. It's a chance, it's an opportunity for them to meet their love of their life and move off to Indiana or somewhere crazy. And so, sorry, poor Indiana. But it's important to try to keep people as close to their communities as possible if we want them to stay and be invested in their kinship networks and their local networks and strengthen everything. So I'd love to see more, like, is your program that people do at distance, or is it, do they need to come to Spokane or Cheney to do training?
Thank you for the lead-in. Why, yes, we do have a fully online program where we allow people to engage in research and internships in their own communities. I don't know why my voice it's just you put me in front of a microphone, I just get all NPR for some reason. I mean, I think that's one of the nice things about our program in particular is that we're trying to meet that need, and that is one of the things we're sure to offer, so students can participate entirely online with our program. Speaking of which, we have a question from one of our online students, Sierra, and she said she was really surprised to hear that Olympia didn't have fluoridated water. Do you foresee any legislative action in the future that might bring more fluoridated water to Washington?
Fluoridation is highly controversial, which I did not know until I moved to Washington State. I grew up in Kansas, where like fluoridation was just the standard. And so I don't think we would probably ever see, you know, something that made fluoridation mandated. It's a community choice that's made by each individual water system about whether they're going to fluoridate their water. And there are concerted campaigns that come around whenever, sort of anti-fluoridation campaigns that come up whenever a community is considering fluoridation. If you're curious, you can Google Port Angeles and fluoridation, because they had a big, long, drawn-out controversy about the decision to fluoridate the water in their community. And so I don't think we'll probably be seeing any. I'll be giving fluoride tabs, I think, for the foreseeable future to my children. And that's a shame, because it is such a wonderful public health innovation, and especially for low-income children, you know, who may not have a stable home life, where there's somebody, you know, who's able to be on top of getting that fluoride tablet prescription fulfilled, is able to deal with it when they run out of the fluoride tabs at the pharmacy, which they do. You know, it's just, it's so many more barriers having to give tabs versus just having to be in the water supply.
And the fluoride tablets taste terrible. My children were not taking them, and I said, I'm like, why aren't you taking these? And I tried one, and I'm like, oh, okay. I get it.
I think mine have sugar in them, because my kid is like, oh, these are great.
Well, let's see, doesn't look like we have any more questions. Any questions from the audience? Charlotte.
I just wanted to say, as an aside, I thought it's really interesting that broadband could be a public health issue. They're kind of debating that issue where I work, so maybe I'll have more of a say now. And separately, what kind of goals does the state have in the next 5 to 10 years for workforce challenges?
So the big things we're working on right now, well, so family medicine has been a big one, although the pipeline's kind of up and going on that. So we're looking now at sort of planning a more serious evaluation of what's happened with the dispersal of those funds. Are we seeing the effects that we hope to see? Behavioral health workforce is definitely something that is both in the short and sort of midterm period what the state is going to be focusing on a lot, I think. They're looking at a variety of different interventions, from both the policy angle, where you look at, is the regulation that's going on truly necessary? Could it be lightened? Could it be simplified? Can you streamline how all this stuff is structured so that it's not so difficult to get into these professions in the first place? And then looking at the billing and who's allowed to bill, how much they're able to bill, because that has a lot to do with your workforce overall. I mean, people need to get paid, and they need to get paid a wage that will allow them to support their families. And for recent history, Medicaid behavioral health reimbursement rates have been very low, and that's, you know, acknowledged at the state level. But you have to find the funds to increase the reimbursement rate so that people can be paid, you know, with master's degrees can make more than $40,000 a year. And if you don't do that, you'll continue to see turnover within the profession. Even if you know, ramp up the number of people you're producing and give them loan repayment, you know, you still won't keep them over the long term. People are economic actors, and they need basic level of financial remuneration. See, I see a question in the pod. Do internships in rural areas have effect on providers and clinicians remaining in the area, or any influx coming from established professionals? Yes, at least both anecdotally and the research, having people train in rural settings or in whatever kind of setting you want them to initially practice in is a best practice, or eventually having those clinicians come and remain in the area or in a similar area. You're not going to keep everybody who comes through a particular internship program, but you'll keep some of them. And that's also an interesting test of how good a administration structure a facility has, because if a facility brings in interns or students on rotation, then you need to make sure that that administration of that facility is then proactively staying in touch, because if you take in a medical student for a third year rotation, then they've got to get through fourth year, and then you're talking like 4 or 5 years before they're able to practice. But if you stay in touch with those particular students, physicians or otherwise, you'll have a much greater chance of hiring them on down the line. People remember who helps them when they were in positions of lesser power, is my belief. And people who are in training, they remember who trained them well and who did a good job, who did right by them. And they'll be more willing to give those employers a hear out down the line.
All right. Well, great presentation, and a lot of information in a very short amount of time. So you will get a chance to review this again. We will have the slides available on our blog, the EWU MPH blog, and we will also put the most recent workforce reports there as well. And we will also have a link. We have a YouTube channel where we're now archiving all of these presentations. This is our 5th one. We've tackled the opioid crisis, suicide prevention, behavioral health transformation in Eastern Washington, and there was one more, maternal mortality. Thank you. And so all of those are archived on our YouTube channel, which you can find access to, and so you can review it at your leisure and kind of refresh your memory. We have another one. This is a bonus month for January. January 25th, we will have the value of water, systems and workforce to ensure the future of our water supply. Clean drinking water is central to the community's health. And even in this day and age, even with the technology available, there are many communities that suffer from lack of clean water, and there's lots of reasons why. Our 2 presenters will talk about the history of that and the implications, and we'll address the shrinking also address workforce shortages for our water systems workers as well. So please share far and wide, as those are 2 presenters for the next one will be here in person, and we like to have a good welcome for them when they get here. Let me see. Renee touched on aging in the rural areas, and I will bring it to your attention that that's our topic for February, is specifically talking about aging and aging services in rural areas. So do put that on your calendars. You can find also on our blog, you'll find the dates for all of the remaining grand rounds. All right. Well, thank you so much all for coming. Thank you again, Renee, for spending time with us today. We really appreciate it.
Thank you all.
And thank you all who joined us online. All right. Have a great weekend.